Hello, good morning, everyone. My name is Molly Mack. I'm one of the chief residents here at Children's, and I'm excited to welcome you to Grand Rounds this morning. It's my pleasure to introduce Dr. Sejal Saglani, a professor of pediatric respiratory medicine at the Imperial College of London, and she's an honorary consultant at the Royal Brompton Hospital in London. Dr. Saglani's research focuses on the investigation of mechanisms underlying the inception of severe asthma and preschool wheeze in children. She's finding novel therapies to improve control, reduce exacerbations, and to achieve disease modification. Dr. Saglani has developed a translational program of research involving an integrated approach to answering questions using pediatric bronchoscopic lower airway samples from carefully clinically phenotyped children, coupled with an age-appropriate neonatal mouse model. Findings are translated and applied in clinical trials. Dr. Saglani has also developed a program to collect airway samples from healthy children having elective surgical procedures to have an age-appropriate control population. We're very excited to welcome Dr. Saglani from London this morning and really looking forward to this discussion.
Well, thanks very much for the very kind introduction. I'll share my slides. I hope you all enjoy the talk. I feel very, very honored to be invited. Very grateful for the invitation. Thank you. So I'm going to be talking about mechanisms that mediate severe childhood asthma and wheezing in preschool children, and hopefully give you a bit of an update on where we are with this kind of field of research. So why am I talking about asthma in children? Well, mainly because actually it's the most common chronic non-communicable disease affecting children worldwide. It's a problem for us all in whichever country we live, so we need to talk about it. For the UK, over 1 million children are affected by asthma, so that's about 3 in every classroom, so a really common problem that we need to think about. But why am I talking about severe asthma? Well, although severe asthma only makes up about 2 to 4% of all children that have asthma have severe disease, the reason it's of interest is because these children use 50% of all healthcare resources for asthma. So although they're a relatively small population, the amount of resource they need, the amount of morbidity they have is completely disproportionate, and we need to improve our management of these patients. The other reason we need to improve our management is that we know from cohort studies that have followed children with asthma from childhood through to adulthood that their lung function is significantly reduced by school age. And if you look on this graph following children with age on the x-axis and lung function on the y-axis, you can see especially the children here in orange. By the age of 10, these are the children with severe asthma already have a significant reduction in their lung function by the age of 10. And then they never catch up. They never get to the controls, which are the yellow ones, or the ones with milder asthma, which are blue. That reduction in lung function is maintained through to adulthood, through to the age of 40. But even more worryingly, if you follow them for even longer, they essentially are susceptible to premature chronic obstructive pulmonary disease in adulthood. So if we don't get severe asthma right in childhood, there's this huge impact for poor health through to adulthood. So it's a really important population to think about. So who is this population? Who am I talking about? Well, these are children aged between 6 and 16 who have continued symptoms despite being prescribed really maximal doses of conventional treatment for asthma. And that includes high dose inhaled steroids plus long-acting beta agonists. And despite that prescription, they carry on having persistent symptoms, frequent exacerbations, and often are on the ICU with attacks of asthma. And this is what's considered high-dose treatment for children. It's been decided by the European Respiratory Society and American Thoracic Society guidelines. And just to note that actually it's not a hugely high dose, about 800 micrograms per day or equivalent of budesonide is enough to put a child in the category of problematic severe asthma, and it's high-dose treatment. So what do we do with these patients in the clinic? How do we investigate them and to then work out what's driving their disease? Well, we undertake a detailed multidisciplinary team assessment, and the team involves clinical nurse specialists, physiotherapists, psychologists, a pharmacist, and yes, some doctors, but often we're not the most important people here, because the role of the team is to work out, A, has the child truly got asthma, but also address comorbidities. And the really important factor here is making sure the children are doing the basics of asthma management right. And so I've put in red here adherence issues. The majority of our children who come to us with problematic asthma, with poor control despite high prescribed treatment, is actually that they're not taking their treatment. Either they're not taking it, or they're not taking it properly, or they're not taking what we think they're taking. So there are a large majority of these patients who have underlying really remediable factors, which once they're addressed, the children can achieve good control, and they do not need escalation of therapy. But there is a definite group, about a third of these patients, who, despite our best efforts to get the basics of asthma management right, continue to have poor control, and they are the group that we would call true severe therapy resistant asthma. So I just want to tell you a little bit about the importance of assessing adherence. Now, the British guidelines tell us that all patients with asthma who are on long-term maintenance therapy should have at least an annual assessment of their adherence to their treatment. And the gold standard for this, really, for patients with severe asthma or difficult asthma, is electronic monitoring. And that's what we use in our clinic. We use these electronic monitors called smart inhalers, which are attached to the inhaler device, and they record the date and time of actuation of the device. Importantly, they have their limitations. They don't actually record efficiency or inhalation, but at least you know whether the device has even been actuated, which is better than nothing. And when we've used this type of monitoring, this is the type of readout that we get. On the x-axis, you see date. On the y-axis is the number of daily doses this child should have been taking. And for this child, they should have been having 4 doses every day. And you can see a lot of white and not much red. And the average adherence was only 33%. This is a child referred to our problematic severe asthma clinic. So when we monitor the patients in our clinic, and there is no hidden agenda here, we're very open and honest. We say we are giving you a monitor so that we can work out whether you're taking your treatment. In a difficult asthma clinic, more than half of the patients have suboptimal adherence. So you can just imagine what's happening out there to the rest of the patients that should be taking their treatment. There's no way of predicting which child will take their treatment or won't. And there's no point asking self-reported adherence, because they will all say, yes, doctor, I'm taking all my treatment. So we really do need objective measures. And this objective monitoring is actually quite useful, because we then come up with 3 distinct groups. A group with good adherence and good control, and they're the gold stars and perfect, and they can probably actually step down on their treatment. The poor adherence group are a challenge. The poor adherence and poor control group are the ones who are difficult asthma. They're the ones who need a lot of time and resource from our MDT to really encourage the family to take the treatment regularly. Lots of education, lots of convincing of why the treatment is important. They're a real challenge. And then the ones with good adherence, but despite good adherence, poor control, are the true severe therapy resistant asthma children who should have an escalation of treatment and additional treatment to what they already have to try and achieve control. Is it worth the effort? Should we do any of these distinctions? What's the point? Well, actually, clinically, they are distinct, these 2 groups. And if you identify difficult asthma and correct it, over time, longitudinally, those patients have actually an improvement in their lung function. And that's what we want to achieve. Whereas the ones with truly severe asthma, we cannot improve their lung function despite getting all of the basics of asthma management right. Their lung function completely plateaus. They need additional treatment to improve their lung function. And the other thing that really sets these children back is asthma exacerbations, asthma attacks. And you can see the difficult asthmatics, if you get their treatment right, up to 6 years later, are having significantly fewer attacks compared to the severe asthmatics whose attacks are ongoing on and on and on. So clinically, they seem distinct. But what about molecularly? Is their airway different for the difficult asthma and the severe therapy resistant asthmatics? Well, to understand that, I just want to give you a reminder of what goes on in allergic asthma in children. What actually is the underlying pathology? Well, this is a healthy airway wall, and in a patient with asthma, continuous exposure to allergen results in the parallel development of inflammation and airway remodeling. So essentially, we end up with a child who has a marked increase in eosinophilic airway inflammation. I'm going to be talking about eosinophils a lot, eosinophils in the airways, so get used to that. The predominant feature is an eosinophilic airway inflammation with structural airway changes, airway remodeling, changes in the epithelium, changes in the subepithelial matrix or reticular basement membrane, and changes in the smooth muscle with an overall thicker airway wall. So do we see these changes in difficult asthma compared to severe therapy-resistant asthma? Well, one of the ways for looking at inflammation non-invasively is to do an induced sputum. So we take a sputum sample following hypertonic saline nebulization, and we look under the microscope. And what's interesting is if we compare blood and airway, the blood does not distinguish difficult asthma and severe therapy-resistant asthma from the point of view of eosinophils. But what's really black and white is that the difficult asthmatics, if you get them to take their treatment, they have no airway eosinophils and their disease can be controlled. Whereas the severe therapy-resistant asthmatics, this is a really characteristic feature, have a sort of a persistent airway steroid-resistant eosinophilia, really consistent feature that we keep seeing. So then we look a bit more directly in our patients with true severe asthma using a bronchoscopy, and we want to know what's going on in the airways, which features of asthma are present by school age. These are school age children in these patients, and we see both in the bronchoalveolar lavage, so the airway lumen, and endobronchial biopsy, so the airway tissue is chocked full of eosinophils in these patients despite high dose treatment. And they have established remodeling. So if you put the biopsies of these patients adjacent to the biopsy of an adult with severe asthma, these remodeling changes are almost identical. They really, really are quite substantial. So they have all of the features of asthma, of severe asthma, already present by school age, by the age of 10, by the time they've got that established reduction in lung function. So what can we do about it? We need to know what's driving it to be able to do anything about it. And the problem is that we cannot keep doing repeated investigations to look in these patients by bronchoscopy before and after treatment to determine mechanisms. So really, we do need preclinical models to investigate mechanism. And that's where we've generated a neonatal murine model of the disease that we see in our children with severe allergic asthma. So we know what it looks like in the children, and we've developed the model to mimic that. So the mice get intermittent inhaled house dust mite exposure. House dust mite is the most common allergen that these children are sensitized to. So they get inhaled house dust mite exposure, and then we come in with high dose inhaled steroid, budesonide, which is the steroid that we use in our patients. And we see that the mice, despite high dose inhaled budesonide, do not have a significant improvement in their lung function. They look like our patients with reduced lung function and increased airway hyperresponsiveness. They still have the persistent airway eosinophilia that I just showed you in the Ballen biopsy of the patients. The gray bars here, persistent despite budesonide, and they have evidence of airway remodeling, which is deposition of collagen around the airways. The matrix around the airways is maintained despite high dose steroids. So we've got a nice model here that actually mimics what we see in our patients. So I feel fairly convinced that if we're going to investigate mechanisms, we're likely to get something reasonable that represents what's going on in our children. So then what is driving it? Well, the most obvious thing to look for are type 2 immune mediators. They're the kind of far and away the most common thing that tends to bring in these eosinophils and cause airway hyperresponsiveness. And interleukin 5 and interleukin 13 are the most common ones to look for. Now, to our surprise, these mediators were significantly lower, back down to control levels in the mice that had received allergen and high-dose steroids. Not quite what we were expecting. But the one mediator that was maintained and elevated despite high-dose steroids was interleukin 33. So why is that important, and what's that got to do with anything? Well, the reason it's really interesting is if you look in genome-wide association studies of children with severe asthma exacerbations, this is one of the main genes that's upregulated consistently. So there seems to be a link with patients And what interleukin-33 is it's an innate cytokine that is released directly by the bronchial epithelium following allergen exposure without the need for antigen presentation, without the need for adaptive immunity. So interleukin-33 can directly cause the downstream effects of the eosinophilia. So this was quite interesting for us, but obviously we've seen it in the mouse, and what about the children? Let's not forget them, okay? So we went back to the samples from our patients, and we looked in the airway biopsies of our children for interleukin-33 expression. And it was really nice to see that the children with severe asthma have increased interleukin-33 expression in their airway biopsies. And what was really interesting was if we related IL-33 to airway remodeling, a specific feature of airway remodeling, the thickening of the reticular basement membrane or the matrix under the epithelium, there was a direct correlation. But of course, this is association. We do have a cytokine that we can find in our patients, and it seems to relate to an important pathogenic feature, but this is correlation. So to prove causation, we had to go back to the mouse model, and we gave the neonatal mice recombinant IL-33 inhaled. So they're not getting any allergen here, they're just getting the IL-33. And we saw increased collagen production, which is what that matrix is made up of, and fibronectin, a more sort of immature form of collagen. So this was really reassuring that our finding was true and that there's a relationship between 33 remodeling and really severe, relatively steroid-resistant asthma. But if IL-33 was increased, what about the eosinophils? What was, what's causing those eosinophils to come into the airways? Well, the cell that IL-33 induces in the airways that then causes the downstream effects is a type 2 innate lymphoid cell. So we need to know, actually, do our patients have those? Because if they don't have those, this is no go, right? We can't prove a hypothesis at all. So innate lymphoid cells are morphologically similar to T helper cells. The key distinction is that the innate lymphoid cells do not have a T cell receptor, but functionally they're able to produce all of the cytokines that T helper cells would produce. So they can produce IL-4, IL-5, IL-13, and they're particularly important in mucosal immunity, so in the gut, in the skin, and in the lung. So do our patients have increased innate lymphoid cells in their airways? Well, they do. We looked in the bronchoalveolar lavage of our children with severe asthma, and we showed that, first of all, the innate lymphoid cells in the airways were significantly higher compared to the blood. So the PBMCs were the blood, and that the children with severe asthma had significantly higher innate lymphoid cells in their airways compared to children who were non-asthmatic controls. That's the LRTI patients. They're the non-asthmatic controls. So this was really interesting, exciting, and very, very reassuring that our mechanistic model was actually probably telling us what's going on in our patients. But then we wanted to, look at, is it just all innate lymphoid cells, or are the Th2 cells also important? And is there a distinction, again, between the difficult asthmatics and the true severe therapy-resistant asthmatics? And to understand this, we went back to the induced sputum, which can be done non-invasively. And what we found was that the children with severe asthma had both increased innate lymphoid cells and Th2 cells, actually, compared to the difficult asthmatics. Blood, not a good marker to distinguish anything. All the action is in the airways of these patients. But I think what I want to emphasize here is quite a lot of the adult literature suggests that the innate lymphoid cells are the be all and end all of severe asthma. But actually, no. I think in childhood severe asthma, there's definite a predominance of type 2 immunity that's being driven by both of these cell types. They both seem to be equally important in driving the disease that we see by a mediator that's upstream, IL-33, which appears to be relatively steroid resistant. So how can we work out really what is steroid resistance? Is there even such a thing? And of course, what I've shown you so far is data with children who are on high dose inhaled steroids. But what happens if we really push them to the extreme and we give them systemic steroids. So then that would really help us to understand whether we've got true steroid resistance, or is it just that you need a high enough dose and everything improves. And so to do this, what we do in our investigation protocol is, after we've excluded the patients with difficult asthma, we go on to the patients with severe asthma and we do a bronchoscopy. But at the time of bronchoscopy, we give them intramuscular triamcinolone, which is a systemic steroid. So they're getting a whacking dose of steroids to really understand, are they really steroid resistant? Or if we give them a high enough dose of steroids, do things improve? And then we look after the triamcinolone at their symptoms, which is the ACT, asthma control test score, lung function, spirometry, exhaled nitric oxide, which is a non-invasive marker of inflammation, and in induced sputum, we look at the actual inflammation. And what's interesting is, if you give a high enough dose of systemic steroids, both the innate lymphoid cells and the Th2 cells do go down. And what also goes down is the type 2 mediator interleukin 5, which is what draws in those eosinophils. So what we're seeing is a group of children who have, I think, a relative steroid resistant disease. If you give a high enough systemic dose of steroids, you can improve things from an immunological point of view. But what about clinically? Well, lung function, interestingly, does not improve despite systemic steroids, but exhaled nitric oxide, the non-invasive marker of inflammation, improves. Symptoms improve, their ACT goes up, and critically, their attacks go down. So if you give a high enough dose of systemic steroids, we can improve these children clinically, and the immune response seems to improve. The problem is, we cannot give children recurrent intramuscular triamcinolone. The side effects are just horrendous. It's just not possible. We can't do it clinically. We need steroid-sparing agents. So what can we use as steroid-sparing agents? Well, what's really nice is we do have more and more of these biologics on the market now that can actually directly tackle the mediators that bring in those eosinophils into the airways. And one such biological is mepolizumab. Mepolizumab is an anti-IL-5 antibody that, for severe eosinophilic asthma. And what IL-5 does is it regulates the growth, recruitment, activation, and survival of eosinophils. So if you block the action of IL-5 with that mepolizumab, the antibody, hopefully you can stop the influx of eosinophils in the airways, and perhaps use it as a steroid sparing agent for severe asthma, because those patients, like I tell you, their eosinophils are really resistant to steroids. So maybe via blocking IL-5, we can stop them coming in. So does mepolizumab work? Well, I can tell you in adults with severe asthma, it works like a dream. And the reason I can tell you that this is really important is because we've got really good clinical trials of efficacy in adults. So DREAM was one of the first trials, multi-center, a large efficacy phase 3 study of placebo, which is the blue line on the left-hand side graph here, versus mepolizumab, which is all the other colors, but mepolizumab in different doses. And you can see on the left-hand axis is the number of exacerbations that those patients had, and the ones with placebo had far greater exacerbations than the ones who got mepolizumab. So the adult data for impact on attacks is excellent. The one thing to bear in mind, though, is although mepolizumab has a great effect on blood eosinophils, it doesn't have a huge effect on sputum eosinophils. And I want you to bear that in mind, because what I've shown you so far is our children with severe asthma have a persistent airway eosinophilia. And so I'm worried that this drug might not be as effective in children as it is in adults because of that persistent airway eosinophilia. And the reason I'm worried is because after we gave systemic steroids, yes, the IL-5 went down in the airways, but the eosinophils didn't go down that dramatically. So I just don't know how effective mepolizumab is going to be in our children with truly severe asthma. Now, you're all going to say to me, but actually, Sejal, don't be stupid. Mepolizumab's already licensed for use in severe asthma, and we're using it. And yes, it is licensed, but that really concerns me, because the data in children from which we've now got a license of mepolizumab is really, I think, not good enough. So I just want you to look at this table carefully. This is the summary of the data of all randomized controlled trials of mepolizumab in adolescents and adults. So the adult trials included adolescents aged 12 to 17 years, and this is split up patients aged 12 to 17 to those aged over 18. Now, what I want you to look at are the numbers over 18 in the trials, at over 1,800. How many children are there, adolescents are there? 37, okay? Really important. The majority of children were atopic, and that's absolutely correct. The majority of our patients have severe aeroallergen sensitization and they're atopic. So it's the right population, but the numbers, I think, are pathetic. And this is the data for children or adolescents of mepolizumab. So for the over 18s, you can quite clearly see really nice narrow error bars and efficacy on exacerbations. Everything is to the left of the neutral line. But look at the data for the 12 to 17-year-olds, really wide error bars. Now, although overall it looks like they're shifting to the left, they might not if we increase the numbers. The total number of children, adolescents, 37, and half of those got placebo. So actually the number that got the drug is even smaller. Based on this data, we now have license to use mepolizumab. It's been approved by the European Medicines Agency and the FDA to use mepolizumab as an adjunctive treatment for severe refractory eosinophilic asthma in children aged 6 to 17. I've only shown you data for 12 to 17. We have no efficacy data for children aged 6 to 11. Despite that, it's been licensed. And this is what really worries me. And it's a message I think that's really important, that we have more and more biologics coming onto the market for severe asthma, targeted biologics for specific mediators. And that's great. But pharma do not want to test them in randomized controlled trials in children. Why? Because it's a small population. There aren't that many children with truly severe asthma, and it's not worth their while. And I'd like your thoughts on that and what you think about that. I'm worried we haven't got appropriate studies of biologics in children. The therapeutic targets are being chosen from adult mechanistic studies. The biomarkers for use of the biologics are being chosen from adult mechanistic studies. We just don't know whether these biologics are really going to work in children with severe asthma. Now, there is one other biologic that has been looked at very carefully in children, and that was actually on the first one on the market 10 to 15 years ago. And it is good for children because the one feature that really characterizes children with severe asthma is that they're very, very sensitized. They have huge atopy. And so the biologic that I'm talking about is omalizumab, which targets IgE. And it's licensed for severe persistent allergic asthma in children aged above 6. And we have good randomized controlled trials for efficacy. I have no problem with that. The problem I have is that it can only be prescribed for children who have a serum IgE between 30 and 1500. But as I've just told you, the majority of our patients have huge sensitization, and at least 1/3 have an IgE outside this range. So we can't even prescribe it for at least 1/3 of our patients, if not up to 50% of our patients. And of those children for whom we can prescribe it, only about 50 to 60% respond. So there's a big gap. I completely accept there's a big gap for additional add-on steroid-sparing treatments for severe asthma. I just don't think we're going about finding the efficacy and evidence for efficacy in the right way. And on the back of that, in the UK, we're currently recruiting into this trial, the TREAT trial, which is actually bringing in all children with problematic severe asthma. We distinguish them after adherence monitoring into difficult asthma and truly severe asthma. And the ones with truly severe asthma will be randomized to receive either omalizumab or mepolizumab, a head-to-head comparison to really see, do these biologics work in this population? And if so, how do they work? It's a non-inferiority trial, so we've hypothesized that both biologics will be equally efficacious. And the other key aim is to really look for biomarkers that for children are the right biomarkers for use of these biologics, and that's ongoing as we speak. So for school age asthma, the sort of messages are that it's characterized by a type 2 phenotype in the majority. And difficult asthma is distinct. It's a distinct clinical and molecular phenotype to true severe asthma. And childhood severe asthma is the ideal phenotype for the current biologics coming onto the market, anti-IL-5, anti-IL-13, anti-TSLP. It's the ideal phenotype, but we need the studies in children to really determine efficacy and biomarkers. So is the current cutoff of blood eosinophils for mepolizumab the correct one for children? I don't know. It's been extrapolated from adult studies. Is the current recommended serum IgE the correct one for children? We don't know. It needs to be looked at. Now, the second group I just want to quickly mention to you all is the story gets even more depressing, because I started off by showing you longitudinal lung function data from children, school-age children with severe asthma, and that low lung function trajectory set by school age, which continues into adulthood. But what's really depressing is what we're seeing more and more now is actually that low lung function trajectory is set even earlier. So if you look at preschool age children who have got wheezing or asthma-like symptoms between the age of 1 and 6, this cohort study from Denmark has followed those children now through to adulthood and shown significantly more of those who had asthma-like symptoms between the age of 1 and 6 have got COPD in adulthood. So that sort of propensity to lifelong impact on lung health isn't set at school age, it's set even earlier. And so I think the preschoolers are even more of a challenge, but need even more attention. And I think what we need to bear in mind is many of us are aware of these clinical phenotypes of preschool wheeze, that there are persistent wheezers who are born with relatively normal lung function, and there are transient wheezers, and then the transient wheezers grow out of their symptoms and all hunky-dory. Well, actually, it's not. If you look at their lung function, whether they were a persistent wheezer or a transient wheezer, by the age of 6, they look identical. And that carries on through to adolescence and then through to adulthood, and then you get COPD. So we need to get out of this mindset of clinical phenotypes of wheeze, and we need to think about pathological phenotypes of wheeze. What's driving preschool wheeze? It doesn't matter whether you're a transient wheezer or a persistent wheezer. I want to know what's driving the wheeze, what's going on in the airway, so we can intervene to stop that loss in lung function by the age of 6. It's set by the age of 6. So, okay, what's going on in the airways? It's easy for me to say that. How do we even know? Well, we have done bronchoscopic studies in very young, severe preschool wheezers. And when we look at the age of about a year, we find that actually these children by far and away don't have much in the way of airway eosinophils or remodeling. But by the age of 3, severe wheezers already have, a group of them already have evidence of eosinophilia and remodeling. So they're on that trajectory to that established eosinophilia and remodeling that we see in the older children, and they're on that lung function trajectory. So it all seems to be happening sometime between birth and the first sort of 6 years of life. So what's driving it? Yeah, we need to know what's driving it so that we can intervene and stop it. Well, one of the things that we know is a really robust risk factor for early onset wheezing is early allergic sensitization. So we've given mice at different ages, we gave them allergen. So the first time they saw allergen was either at 3 days of age, which is about infancy, or at 15 days of age, which is about adolescence, or at 60 days of age, which is about adulthood. They hadn't seen allergen before that. It was exactly that the age determined what happened to them in response to allergen. And what's really interesting is that the mice that got allergen early in infancy, in that early period, were the ones that had a really exaggerated, exacerbated lung and airway eosinophilia, exacerbated airway hyperresponsiveness, and increased type 2 cytokines that we've been talking about, both IL-5 and IL-13. So there's something very much about early life allergen exposure resulting in this kind of type 2 skewing and susceptibility to development of asthma and altered lung function. But what is it? Well, of course, the advantage of doing experiments in mouse models is that you can look in very naive mice longitudinally at different ages. And that's where it gets really, really interesting, because if you just look in the airways of naive mice, these mice are just in a pathogen-free environment. The one thing that you can see that changes with age, no intervention at all, they're just different ages, is that the very young mice have a much lower bacterial load in their airways, and lungs compared to the adolescent mice compared to the adult mice. And the makeup of that microbiome or microbial profile is very, very different. In that first year of life, it's a very homogeneous and much less diverse microbial profile. And by adulthood, it's a much more diverse and bacterial load heavy microbial profile. So there's a definite development of the airway microbiome with age. And the reason that's important is there's a direct impact on the immune responses that result from that. And if you look at the immune responses in these mice at different ages, you see that the younger mice, although they have T regulatory cells, they're predominantly Helios positive. But the older adult mice have almost half Helios negative T regulatory cells, which functionally are much more capable of fighting the allergen exposure and the type 2 immunity. So functional immunity is much more mature and developed by adulthood. So this is really interesting because it makes a link between why that early life allergen exposure might result in exacerbated type 2 immunity. Is it as a result of the developing microbiome? Well, that's in mice, you might say. That's not relevant to kids, is it? Well, maybe it is, because one of the most robust findings that we have of protection from asthma and allergy in children is growing up on farms. This is European data, and the pink bars here represent children that grew up on cattle farms, and they had much lower asthma and allergy compared to those who were not brought up on cattle farms. And there's some really, this is lovely data from North America, looking at the Amish and Hutterite communities. And the reason they're interesting is that they have a really similar genetic background. The only thing that's different about them is one thing in their environment. Their lifestyle is really, really similar. But the one thing that's different is their farming practices. The Amish practice traditional cattle farming, and the Hutterites practice industrialized modern cattle farming. The Amish have a really low prevalence of asthma, very protected. And the Hutterites, same asthma prevalence as the indigenous population. So it, it really allows us to nicely narrow down. There's something specific about this environment that's protective. What is it? Well, if you look at that dust from the Amish households, the dust these kids are breathing in from the moment they're born, it has significantly more endotoxin. Where does endotoxin come from? Bacterial cell walls and microbes. So is it the microbiome of the farmyard cattle farm environment that's protecting from asthma and allergy? Well, of course, that's epidemiological associative data. We have to go back to mechanistic preclinical models to show mechanism, and we've done that. So we, in our sort of neonatal house dust mite model, we came in with Acinetobacter awafi, which are the microbes found in those cattle farming environments. We gave the mice inhaled Acinetobacter awafi in parallel with the allergen exposure, and the eosinophils in the lungs went completely down. The airway hyperresponsiveness completely back down to control levels, lung IL-13 levels right down. And mechanistically, it was actually the CD4 13 positive T cells that were reduced, not the innate lymphoid cells. And that's why I've made a point of saying that in childhood disease, I think both cell types are equally important, but it was definitely the CD4 13 positive T cells that were right down. So this is now really exciting, because in the context of an allergen-induced disease, we have a potential intervention to come in with, to manipulate the early life airway microbiome to perhaps finally protect from the development of asthma. That's for allergen-induced airways disease, but there's a problem. And that is that the majority of our preschool wheezers are non-allergic. So it's quite the opposite to school age asthma. Really interesting. Preschool wheezing is predominantly 3/4 non-allergic and non-sensitized. But by school age, these kids are now, they become predominantly sensitized. So that in itself is really, really interesting. But what's driving non-allergic wheezing? So these viral wheezers that do our heads in, they're a nightmare for us to deal with. What's driving their disease? Well, we looked in the airways of our children with severe preschool wheezing, and we've looked at our cohort that were bronchoscoped between 2010 and 2016, and we did see actually only 1/4 had aeroallergen sensitization. But despite that, 3/4 were getting inhaled steroids. Why? Because we're desperate. We don't know how to treat these patients. But the other really interesting finding was that at least 1/2 of these patients when they have a bronchoscopy, when they're stable, this isn't during an attack, they're stable, they're well enough to have a bronchoscopy, have evidence of positive bacterial infection by traditional culture. And that's regardless of their clinical phenotype, whether they're a multiple trigger persistent wheezer or an episodic viral wheezer, half of them will have positive bacterial culture in their bronchoalveolar lavage. And the ones that do have positive bacterial culture now have increased airway neutrophils. It's not eosinophils, it's a predominance of neutrophils. And that's regardless of their atopic status, and it's regardless of prescribed inhaled steroids. So this was really interesting to us, but we were thinking, but hold on, what is going on? Is this really true? Are we just, making the data tell us what we want? So to try and really be unbiased in our analysis and just completely put in objective markers of inflammation and infection, we did an unbiased cluster analysis of data from 135 children, preschool children who had a clinically indicated bronchoscopy for severe wheezing and respiratory symptoms. And the only thing that went into the analysis, nothing clinical, no clinical phenotypes went in, was presence or absence of allergen sensitization, presence or absence of bacterial culture by traditional culture, not microbiome, presence or absence of virus, blood and bowel eosinophils and neutrophils. And we got 4 clusters. And it's really exciting because one of the clusters is a highly allergic atopic cluster. That's that quarter of patients. And there was another distinct cluster with predominant virus and bacterial infection. And the atopic cluster had a predominance of eosinophils, and the infection cluster had a predominance of neutrophils in their airways. So whether we looked in a hypothesis-driven way, like I showed you initially, or whether we look in an unbiased, completely unbiased way, we're getting these 2 big phenotypes quite consistently. So this is our current hypothesis, that I think that there are 2 essential objective phenotypes of preschool wheezing, one driven predominantly by allergies and one driven predominantly by infection. The one driven by allergies is associated with eosinophils, and for treatment we would give those children inhaled steroids, but for prevention and to really stop that long-term impact on lung function, I think the future is in manipulating the microbiome. And for the ones with the bacterial infection predominating in their airways with the neutrophils, I think an approach is targeted antibiotics. That's not been proven. We don't have any randomized trials that have looked at this, but I think that could be the way forward. And actually, even in that group, manipulating the microbiome to go from a sort of a bacterial heavy microbiome to a more diverse, rather than a single bacteria predominating, to a more diverse microbiome, might also be very, very helpful. So despite the 2 clinically pathologically distinct phenotypes, perhaps the way to manipulate and prevent could be the same via the microbiome. So what have I tried to tell you about early life wheezing, inflammation, and asthma? Well, I hope I've convinced you that regardless of the clinical phenotype, there's probably 2 key inflammatory phenotypes in this preschool wheeze age group. And I think manipulating the microbiome may be a way of preventing them from going on to get asthma into adolescence and adulthood. This is completely me and my hypothesis and speculation, but the data that we have seems to support this. And I think this perhaps is finally going to give us a way forward to prevent that significantly reduction in lung function, which we can never get back to normal, and change that and get that back to on a normal trajectory so that all these kids don't end up in our adult physician's clinic with COPD. And that's all I've got to say. So thank you very much.
Great. Thank you so much, Dr. Saglani, for that robust presentation. I will be reading some questions from the chat. Please feel free to continue to send them in. We have a question from Dr. Kazmersky, one of our pediatric pulmonologists here. She says, thank you for a great talk. Minor point in question, but I wondered how successful you are at getting kids to produce sputum after a dose of hypertonic saline.
Yeah, that's a really good question. So for the older children, our success rate is between 70 and 80%. It's a lot to do with experience, an experienced technician, not the experience of the child. You do need people, the better, more the sputum inductions our physiotherapists or our clinical fellows do, the better they get at it. So in the older children, it's about 70 to 80% success rate. We're doing induced sputum in our younger patients as well, the preschoolers, mainly to look for infection because of that phenotype I've just shown you. And for them, obviously, they don't expectorate. So the end of the induction is with a sort of a catheter and oropharyngeal suctioning. And in there, again, the success rate is very, very safe. And the success rate is about 80% for a good sample for infection. Yeah.
Wonderful. Thank you. Great. Another question from a pulmonologist, Dr. Forno here. Thank you for such an interesting talk, translating basic science findings to clinical application. What you describe on mepolizumab matches the quote unquote tepid response we have seen in our own severe asthma clinic. Yeah. Do you have more hope for anti-TSLP tezepelumab,
yeah.
or perhaps anti-IL-33 antibodies?
Yeah, so thanks, Eric, for that question. I would mirror your tepid response for mepolizumab. That's why we're doing the head-to-head comparison of omalizumab and mepolizumab, because I think there's some feeling out there that suddenly mepolizumab is going to be the wonder drug, and I don't think it is going to be for children. We haven't found TSLP in our patients with severe asthma. The only innate mediator that we haven't even found IL-25. The only innate mediator that seems to be giving us a signal is IL-33. So I would be interested in looking at IL-33 in our patients. I don't know how well those trials have gone on in adults because the data haven't been published. So I think maybe that's a mediator that actually it's a seesaw and it might actually be the right one for children, and perhaps not so good for adults. But of course, because it's children, convincing the companies to just do a pediatric trial, that's I find that's the biggest challenge. If you've got any suggestions of how to improve that, it would be great. But I think we may have potential in 33. I'm less sure about TSLP because we just can't find it in our children. Yeah.
Excellent, thank you. Dr. Larkin, one of our allergy and immunology attendings here, says, thank you for a great presentation. Could you comment on your clinic's experience with using dupilumab?
Yeah.
We have had very good response in our severe asthmatics after trialing several others.
So thank you for that question. So we can't use dupilumab in the UK. Really frustrating, not licensed for severe asthma. I think you're absolutely right. The phenotype that we have in children is absolutely aligned to respond to dupilumab. So anti-IL-4, anti-IL-13. I think it's going to be the one biologic that's going to be, in fact, I think it's going to be better than mepolizumab. I really do. It's not licensed yet for us to use, certainly in the UK. In Europe, the license is there for, I think it's for 12 and above. And trials are ongoing for the sort of 6 to 11-year-olds. And I think that data is about to come out, or perhaps it was shown at ATS. So I haven't been able to use it yet, but I think dupilumab's the way forward. Completely agree. What I think is a missed opportunity, you've probably seen that I think what we miss out on in children is not looking at mechanism. These are new drugs. They've never been used. We've got the opportunity to do human experiments. Induced sputum can be collected, blood can be collected, and I just think we're missing out on the opportunity to work out how these biologics are working in our patients, and I feel that's a shame. That upsets me, but I do think dupilumab will be a good drug for these patients. Of course, the challenge is which drug in which child, and unless we do the biological treatments, the mechanistic studies, we're not going to know, and I think we need to take that on as a pediatric community. Yeah.
Great. Dr. Gayeta, one of our pulmonology fellows, says, thank you for your fantastic talk, Dr. Saglani. Given the two distinct phenotypes for preschool wheezers, how do you personally decide which preschool wheezer in the clinic gets inhaled corticosteroids if they haven't undergone testing to determine if they're eosinophil or neutrophil predominant? Do you order testing, trial ICS, or if you trial ICS, for how long?
Yeah, so really nice question. I didn't have enough time to tell you about all the data that we have about the children with air allergen sensitization and preschool wheeze. There's a really nice trial that's been done, the infant trial. It's published in JACI by Anne Fitzpatrick. And she showed really nicely that there's 2 biomarkers that really help you to work out which preschool wheezers will respond to inhaled steroids. And those 2 biomarkers are evidence of air allergen sensitization. So skin prick testing is what I do in the clinic, and elevated blood eosinophils. So if you have when the child is stable, not during an attack, but in your clinic, if you do a full blood count and you find blood eosinophils of 300 cells or greater, and or aeroallergen sensitization, you're likely to find the group that will respond to inhaled steroids. And I do my best to do those 2 tests in the clinic for these patients. If you're not able to do those tests, they're relatively easy, right? They're not a big deal. I think we should be doing objective tests rather than just plowing in steroids. But if you're not able to, then certainly you may try inhaled steroids, but I would only trial them for 12 weeks and then bring the child back and see if there's been a response. And please remember, just like the basics are important in the older children, they're even more important in the younger children. And we've shown with our preschoolers with the adherence monitoring that it's even worse, actually. Only 2/3 have good adherence. So you've got to make sure that you've shown them the technique, that they're doing it properly and they're taking the treatment before you decide that it hasn't worked and before escalating up and up. For the neutrophilic phenotype, it's harder. Completely agree, it's harder, especially because we don't have randomized trials at the moment that have shown a benefit of antibiotics. And I think that's a big gap in the preschool wheeze literature. But if I was struggling with a preschool wheezer, I would do an induced sputum to look for infection. And if they have bacterial infection, I give a 4-week course of targeted antibiotics to see if they respond. That's the approach I'm taking, yeah.
Great, thank you. We have another question from Dr. Forno. He agrees with you. We've certainly seen a much better response with dupilumab here, hopefully approved in the UK soon. On the topic of microbiome, several studies of probiotic during pregnancy and or infancy have shown protection from eczema or atopic sensitization, but the results are not so great for asthma in school age. Do you think this is because of the quote unquote wrong bacteria being used, or perhaps because trials are quote unquote lumping all subphenotypes together and the true signals get lost?
So I think it's both. Really good point. Again, I didn't have time to show the data, but there's a really nice recent randomized trial in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. Mediators, the first author, which is a randomized trial of children under 3 who got sublingual mixed bacterial lysates. So the bacteria in that compound, it's called MV130, are the bugs that we see when we culture bacteria in our patients. But so it's a small amount of each of those bacteria, Moraxella, Strep pneumoniae, Staph aureus. So it's a mixed compound of those lyophilized bacteria given sublingually to children who are non-allergic under the age of 3. And they've shown a really nice reduction in wheeze attacks over the subsequent year. So I think you're right, probiotics are just too general, and we need to have, even manipulating the microbiome needs to be targeted. Completely right. So I think that's where we've gone wrong. We've not chosen the right patients, and we've not chosen the right intervention to date. Yeah, but I think we've got scope. I really do. But we need, it's the right compound and the right route of delivery. I'm not sure, because probiotics are given orally and they manipulate the gut microbiome. And I accept there's a gut-lung axis, but actually we've given those farmyard bugs inhaled and the kids are inhaling the dust. So route is really important, I think, as well, as the actual compound. Yeah.
Thank you so much, Dr. Saglani. If there's no other questions at this time, we invite everyone to join us over with our presenter at the meet and greet, and the link for that is in the chat.